Hey friends, in this class we are going to discuss the topic peritoneum. Okay, important points related to the topic peritoneum. Okay, so I hope you will be knowing peritoneum is a thin serous membrane covering the majority of the abdominal organs and the pelvic organs. Okay, it is a thin serous membrane covering the majority of the abdominal and the pelvic organs. Okay, so some of the abdominal organs, they are not covered by peritoneum. Okay, which are called as retroperitoneal organs, which are located behind the peritoneum. Okay, so called as retroperitoneal. Retro means behind. Okay, so what is the nature of all the retroperitoneal organs? Yes, all the retroperitoneal organs are fixed. Okay, they are fixed, immobile. Okay, so we have to know what are the various retroperitoneal organs or what are the fixed abdominal organs. Okay, so kidneys, ureters, suprarenal glands. Okay, all these are posterior abdominal wall organs. Okay, so retroperitoneal organs will be resting over the posterior abdominal wall. Okay, they are directly resting over the posterior abdominal wall. Okay, fine. Kidneys, ureters, suprarenal glands. Okay, then major part of the duodenum and the major part of the pancreas, they are also retroperitoneal. Okay, what is the exception? Yes, except the initial 2.5 centimeters of first part of duodenum, D1, first part of duodenum. Okay. Similarly, the major part of pancreas except tail of pancreas. Okay. So in the last session, yesterday's session, we have talked about the pancreas. The only mobile part, or you can say the only intraperitoneal part of the pancreas is tail of pancreas, isn't it? So the remaining major part of the pancreas, head, neck, body, all are retroperitoneal. Okay. Then when you talk about the large intestine, ascending colon, descending colon, cecum, rectum, all are retroperitoneal. Okay. Now, can you tell me the intraperitoneal organs? Intraperitoneal organs means that particular abdominal organ is covered by peritoneum completely. On all sides, it will be covered by peritoneum. Okay. And what is the nature of the intraperitoneal organs? Yes, they are mobile. Okay. Fine. So what are the various intraperitoneal organs? Stomach. Okay. Why I am saying stomach is an intraperitoneal organ? Because it is suspended by some peritoneal folds like greater omentum, lesser omentum. Okay. Okay. And why I am saying spleen is an intraperitoneal organ? Because it is suspended by some peritoneal folds called as gastrosplenic ligament, renal ligament and all. Similarly, liver is intraperitoneal because it is suspended by falciform ligament, coronary ligament, triangular ligaments and all. Okay. Then jejunum and ileum, the entire length of the jejunum ileum, small intestine, they are suspended by one peritoneal fold called as mesentery. Then out of the various parts of the large intestine, transverse colon, sigmoid colon and appendix, these three are the three parts of the large intestine which are intraperitoneal are these three. Okay. Transverse colon, sigmoid colon and appendix, because they are suspended by some peritoneal folds like transverse mesocolon, sigmoid mesocolon and mesoappendix respectively. Okay. So the question may be asked, which of the following is a intraperitoneal organ? Which of the following is an retroperitoneal organ, like that? Okay. All are retroperitoneal organs except like that. So I want you to remember which are the retroperitoneal organs. Okay. And which are the intraperitoneal organs. Okay. Fine. And now we are going to talk about one topic called as lesser sac and greater sac. Okay. So actually, between the two layers of the peritoneum is a thin membrane which is consisting of two layers, outer parietal and inner visceral peritoneum. Between the two layers of the peritoneum, we have some narrow space called as peritoneal cavity. Okay. Between the two layers of the peritoneum, we have the peritoneal cavity, which is filled with the minute amount of peritoneal fluid. Okay, fine. And remember, see this diagram, just a minute. So actually liver, this is the liver. Liver has been reflected upwards. Liver has been retracted or reflected upwards in order to expose the underlying structures. Do you see the stomach? Do you see the stomach here? Okay, in this diagram, this is the right side and this is the left side of the abdominal cavity. Okay, so you are able to see the spleen here. Okay, spleen, fine. Yeah, so now do you see, actually this is the gallbladder, which is located on the inferior surface of the liver. Okay, fine. Do you see one peritoneal fold? This yellow color peritoneal fold, isn't it? What is the name of the peritoneal fold I am marking now? Yes, this is the lesser omentum. Lesser omentum. Okay, so actually you will be knowing. Right now I am highlighting the lesser curvature of the stomach. Okay, this is the lesser curvature of the stomach, isn't it? So from the liver to the lesser curvature of the stomach, there is one peritoneal fold, yellow color peritoneal fold extending, called as lesser omentum. Similarly, you will be knowing this is the greater curvature of the stomach, greater curvature of the stomach, isn't it? So do you see one peritoneal fold hanging downwards from the greater curvature of the stomach? What is that peritoneal fold called as? This yellow color. Yes, greater omentum. Okay. So lesser curvature and greater curvature of stomach, they will give attachment to the lesser omentum and greater omentum, which are peritoneal folds. Okay. And remember, this lesser omentum, okay, lesser omentum consists of 2 layers. It is consisting of 2 layers, and greater omentum consists of 4 layers. Okay. And this greater omentum, okay, it is also called as policeman of the abdomen. Okay. Why it is called as policeman of the abdomen? Because this greater omentum contains numerous lymphocytes, aggregations of lymphocytes, which are involved in the defense mechanism. Okay. They prevent the spread of infection from one organ to the another abdominal organ. So it is also, greater omentum is also known as policeman of the abdomen because of the protective function. Okay, fine. Remember, are you able to see the lesser omentum and greater omentum here? We have to remember what are the lesser omentum contents. What are the 5 contents of the lesser omentum? Okay, what are the 5 contents of the lesser omentum? Yes. If you see, right now I am tracing the lesser omentum along the attachment, okay, of lesser curvature. Okay, so along the lesser curvature of the stomach, the lesser omentum contains the following structures along the lesser curvature. What are they? Exactly, 2 contents will be there, called as right and left gastric vessels. Okay, right and left gastric vessels, both are contents of lesser omentum along the lesser curvature of the stomach. Okay, actually left gastric artery will be running like this. Okay, sorry, right gastric artery will be running upwards like this. Left gastric artery will be running downwards like this. Finally, the right and left gastric vessels, mainly arteries, they will anastomose with each other. Okay, so 2 contents of lesser omentum along the lesser curvature, as we studied, they are right and left gastric vessels. Okay, and right now I am tracing the right free margin of lesser omentum. Okay, right free margin of lesser omentum. Okay, so what are the contents of the right free margin of lesser omentum? The right free margin of lesser omentum, okay, contains 3 structures. Okay, what are the 3 contents of the right free margin of lesser omentum? Exactly, portal triad structures. Okay, portal triad structures. You can see the 3 structures within the right free margin of lesser omentum, the one I am marking in the diagram. Okay, what are the 3 structures constituting the portal triad? Yes, the green color structure you are seeing here is common bile duct, and red color is hepatic artery. So hepatic artery, okay, then portal vein, that blue color structure is portal vein. Okay, then we have the common bile duct, hepatic artery, portal vein, and the bile duct. These are the 3 structures collectively called as portal triad structures, which are located along the right free margin of lesser omentum. So please remember the 5 contents of lesser momentum. What are the 2 contents along the lesser curvature? What are the 3 contents along the right free margin of lesser momentum? Fine. Okay. Fine. Now, again, the diagram is showing the stomach and the peritoneal folds. Okay. So this is the lesser curvature of the stomach, and this is the greater curvature of the stomach. Okay. So obviously, this is the lesser omentum, which is a peritoneal fold. This is the greater omentum, which is also a peritoneal fold. Fine. And you know the 5 contents of the lesser omentum, right? Okay. Now, just behind the stomach, okay, as well as just behind the lesser omentum, we have one narrow space. Okay. Narrow space means a small space of the peritoneal cavity, which is named as lesser sac. See, previously I told lesser omentum and greater omentum, which are peritoneal folds, okay, membranes. Now I am talking about 2 terms, lesser sac and greater sac. Okay, so what is lesser sac? Lesser sac is a small, okay, it is a lesser. That means it is a small part of peritoneal cavity. Okay, lesser sac is a small part of peritoneal cavity. What is the location? Yes, located behind. Okay, it is located just behind the stomach. Lesser sac is a small part of peritoneal cavity located mainly behind the stomach, also behind the lesser omentum. Okay, the remaining entire major part of the peritoneal cavity is called as greater sac. Okay, other than lesser sac, which is located behind the stomach and behind the lesser omentum, the major part of the peritoneal cavity is called as greater sac. Okay, major part of the peritoneal cavity is called as greater sac. Okay, and remember, the lesser sac and the greater sac, which are peritoneal cavities, spaces, both are communicating with each other through a narrow space. Okay, through a narrow space. That is the space I am marking now. Okay, if you introduce your finger just behind, this is the right free margin of lesser omentum, isn't it? This is the right free margin of lesser omentum containing the portal triad structures, right? So just behind the right free margin of lesser omentum, there is a narrow space. Okay, narrow space or narrow opening through which the greater sac communicates with the lesser sac. What is the name of that opening? Narrow opening. Exactly. It is called as epiploic foramen. Okay. Epiploic foramen. So what is epiploic foramen? It is a epiploic foramen is a narrow opening. Foramen means opening. Okay. Narrow opening through which the greater sac and the lesser sac both are communicating with each other. Okay. And before going to the boundaries of the epiploic foramen, remember I told you lesser sac. Okay. Lesser sac is otherwise known as omental bursa. This one we have to remember. Okay, lesser sac is also known as omental bursa. Okay, lesser sac is also known as omental bursa. Okay, why it is called as omental bursa? Because this lesser sac, which is a space cavity, helps for the distension of the stomach. Okay, it helps for the distension of the stomach. Okay, so it is called as, it is also known as omental bursa. Okay, fine. In this diagram, you can easily understand the location of the lesser sac and the greater sac. Okay, this is the sagittal section. Okay, this is the sagittal section of what? Abdominal cavity, abdominal and the pelvic cavity. Okay, so mid sagittal section of abdominal cavity and the pelvic cavity, showing what? The lesser sac and the greater sac. Okay, so do you see the liver in this diagram? This is the diaphragm. So just below the diaphragm, you are able to see the liver. Then you are able to see the stomach, isn't it? Stomach. Fine. So what is the peritoneal fold I am marking now? Extending between liver and lesser curvature of the stomach. Yes, peritoneal fold called as lesser omentum. And what is the peritoneal fold hanging downwards from the greater curvature of the stomach? Yes, it is the greater omentum. Actually, right now I am marking the first 2 layers of the greater omentum, And right now I am marking the third and fourth layers of the greater momentum. Third and fourth layers. Totally, I told you greater momentum consists of 4 layers, isn't it? So from this diagram, you can clearly understand, okay, the space, okay, the space which is located just behind the stomach as well as just behind, okay, just behind the stomach as well as just behind the lesser momentum is the lesser sac. In this diagram, you will be having the orientation of anterior, posterior, superior, inferior, right? Okay, fine. So the remaining entire, okay, the remaining entire peritoneal cavity, the larger part of the peritoneal cavity, okay, which is colored differently, is called as greater sac. Okay, and what is the only communication between the greater sac and lesser sac? Yes, through a narrow opening called as epiploic foramen. Narrow opening called as epiploic foramen. Okay, so now we have to remember the applied aspects of the omental bursa, otherwise called as lesser sac. Okay, so you know already the lesser sac is located just behind the stomach, isn't it? So if there is ulcer, okay, if there is ulcer involving the posterior wall of the stomach, if there is ulcer, gastric ulcer, okay, gastric ulcer involving the posterior wall of the stomach, okay, the contents of the stomach will be, okay, the contents of the stomach will be leaking into the part, lesser sac, okay. If there is, okay, gastric ulcer involving the posterior wall of stomach, and if it is leading to perforation, okay, so the perforated posterior gastric wall ulcer, okay, the gastric contents will obviously get collected, okay, it will leak from the stomach and it will get collected in which of the following area? That is the question. The answer is collection of fluid will be within the lesser sac, otherwise called as omental bursa, also called as omental bursa. Okay, this question has been asked several times. Okay, and also if there is pancreatitis, inflammation of the pancreas, pancreatitis. Okay, so during this condition called as pancreatitis, otherwise called as pseudocyst of pancreas, okay, in this condition also there will be collection of fluid within the lesser sac. If fluid will be getting collected in the lesser sac. Okay, so these are the two possible causes for the collection of fluid in the lesser sac, otherwise called as omental bursa. One is posterior gastric wall ulcer perforation, and another one is pseudocyst of pancreas, which is occurring due to the condition pancreatitis. Okay, you know, lesser sac is located behind the stomach. Okay, and there are certain structures called as stomach bed structures. What actually, this is the stomach in this diagram. Okay, stomach has been reflected upwards. Actually, this is the posterior wall of the stomach. Okay, posterior surface or posterior wall of stomach. Okay, so if you reflect the posterior wall of the stomach, okay, if you reflect the stomach upwards, just behind the stomach, what is this space called as? Yes, this space is called as lesser sac, isn't it? Lesser sac. So the lesser sac is posteriorly related to various structures like left kidney, left suprarenal gland, okay, left dome of diaphragm, like that. Various structures will be related. Okay, fine. Yes, now for the next 5 minutes, let's talk about the another important topic, namely epiploic foramen. Okay, epiploic foramen, which is also called as foramen of Winslow. Okay, epiploic foramen, otherwise called as foramen of Winslow. Okay, which is again asked repeatedly. Mainly the image-based question will be asked. Okay, so what is epiploic foramen, otherwise called as foramen of Winslow? Yes, it is a foramen. It is an opening through which greater sac and lesser sac both are communicating with each other. Okay, and the vertebral level of the epiploic foramen is T12, 12th thoracic vertebral level. Okay, this diagram is clearly showing the location of epiploic foramen. Right now in the diagram, I am marking the epiploic foramen, isn't it? Okay, and listen, this diagram shows the boundaries of the elliptic foramen. Okay. So as you see here, this is the orientation in this diagram, which is anterior, posterior, superior, inferior. Have the idea for this diagram. Okay. So what is the superior boundary for the elliptic foramen? Yes, the elliptic foramen is bounded superiorly by the caudate process of liver. Caudate process of liver. Okay. What is the inferior boundary for the elliptic foramen? Yes, it is first part of duodenum, D1. First part of duodenum, D1. Okay. And what is the anterior boundary for the elliptic foramen? Yes, this is the lesser omentum. This light blue, light green color structure is peritoneal fold called as lesser omentum. Okay. So, you know, the right free margin of lesser omentum contains the portal triad structures, okay, which are forming the anterior boundary of the elliptic foramen. Okay. And what is the posterior boundary for the elliptic foramen? Exactly. IVC. Posteriorly, the elliptic foramen is bounded by inferior vena cava. Okay. And the vertebral level of elliptic foramen, as we studied just now, T12. T12. Okay. Fine. So that's what I have written here again. Boundaries of elliptic foramen. Okay. Anteriorly, it is bounded by the right free margin of lesser omentum, which contains the portal triad structures, namely hepatic artery, portal vein, and the bile duct. Fine. Okay. Posteriorly, the elliptic foramen is bounded by inferior vena cava and the right suprarenal gland. Right suprarenal gland. Okay. And superiorly, the caudate process of liver, and inferiorly, the first part of duodenum. First part of duodenum. Okay. Yes. Actually, this question has been asked in the recent exam. Okay. So this was the question asked. Which of the following structure forms the superior boundary of marked foramen? It was an image based question. So the elliptic foramen was marked. Okay. And the question was, which of the following among the four options, which of the following forms the superior boundary of elliptic foramen? I think you can answer this question. The elliptic foramen is superiorly bounded by what? Yes, liver, caudate process or caudate lobe of liver. Okay. So again, once again, just for your practice, the diagram showing the boundaries of elliptic foramen. Okay. Boundaries of elliptic foramen or foramen of Winslow. Okay. The orientation for this diagram, you know, anterior, posterior, superior, and inferior, isn't it? So, this is the elliptic foramen, otherwise called the foramen of Winslow. You know, this is the lesser omentum, isn't it? This is the right free margin of lesser omentum. This is the right free margin of lesser omentum. I am marking now, okay, which is forming the anterior boundary, which contains the portal triad structures. Right free margin of lesser omentum containing portal triad structures. What is the posterior boundary for the elliptic foramen? Exactly. It is the inferior vena cava as well as right suprarenal gland at the vertebral level of T12. Okay. And what is the superior boundary for the elliptic foramen? Superiorly, it is bounded by caudate process of caudate lobe of liver. Right? What is the inferior boundary for the elliptic foramen? First part of duodenum. Right? Inferiorly bounded by first part of duodenum. Okay. The remaining things we will see in the next class. Okay. Tomorrow. Okay. So in this diagram, okay. Right. So these are the two parts of the peritoneal cavity. Okay, the peritoneal cavity is divided into greater sac. The major part of the peritoneal cavity is called as greater sac. A small part of the peritoneal cavity which lies behind the stomach and behind the lesser omentum is called as lesser sac. Okay. So yes, the things related to this diagram we will see in tomorrow's session. Okay. Thank you all.
Yeah. So let's start with our today's discussion. So the question for today is, okay, all are true regarding severe combined degeneration of spinal cord except A, B12 supplement improves the condition. B, columns involved are dorsal, lateral, copper deficiency causes similar symptoms, and all cases with neuro impairment cause macrocytosis. So among these following questions, what is the false option? Okay, first for this you should know what is severe combined degeneration of spinal cord. Nothing but, as most of you would have guessed, it is due to B12 deficiency. So actually what happens there and how and all it progresses, let's see one by one. Okay, yeah. So first, if you see in the spinal cord, B12 deficiency affects what fibers? This is what you should know. See, in the spinal cord, if you take the myelin, okay, the heavily myelinated fibers will be the one which will be affected because this myelination requires vitamin B12. If you study in biochemistry, B12 will be a part in formation of the lipids involved in the formation of myelin sheath. So this heavily myelinated fibers in spinal cord, if you see, the number one is the posterior column fibers or the dorsal column tractor, which is nothing but which contains the proprioception and the tactile sensations. So if this heavy myelinated fast express tract is affected, so what will happen? The proprioception won't be relayed properly. Proprioception means what is the position of your joints in space. This information won't be relayed to your brain properly. So at one point of time, you will be feeling that your position in space is not balanced. Your balance is affected due to problem not in the cerebellum, not in the cortex or somewhere, due to problem in the sensory system. So this disturbance in balance, which is called ataxia, due to affection of sensory system, myelinated tract, is called sensory ataxia. Okay, this is the manifestation due to disturbance in proprioception. Next, if you see tactile sensation. Tactile sensation, if it is affected, this will be manifested as tingling sensations as well as paresthesias. Okay, so if dorsal column is affected, two things will be there. One is tactile sensation, paresthesias, and proprioception will be lost, leading to sensory ataxia. Just a minute. So Yeah. So the next tract to be affected is the lateral corticospinal tract. This is the motor tract which we found, which was heavily myelinated. Next tract, motor tract, which is heavily myelinated, is lateral corticospinal tract. That is a sensory tract. This is the motor tract. Now, try guessing what will happen if this motor tract is affected. See, if a motor tract is affected at a particular segment, then at that particular segment, the features will be of lower motor neuron type. And the segment below those affected areas will behave as upper motor neuron type. Because the segments below this area will be thinking like their upper motor neurons are affected. So the features of upper motor neuron paralysis will be there, like hyperreflexia, hypertonia, spasticity, all those things will be there. Clonus. These things will be there in the lower limb. And in the upper limb, you can find element features like hypotonia, areflexia, okay, flaccidity, all these things in upper limb. And in lower limb, if you see spasticity, increased reflexia, human findings in upper limb and element findings at a particular segment where it is affected, like upper limb or lower limb, anywhere. Okay, that contributes this SACD, severe acute combined degeneration of spinal cord. Why combined? Because first tract which was affected was a sensory tract, and the next tract which was affected was a motor tract. So only we are calling it as combined degeneration of spinal cord. Okay. Yes. Next, if you see, let's see the blood findings, how it correlates. We know the B12 deficiency causes macrocytic anemia, and B12 deficiency causes defect in myelination and these neuro findings. But how this appears, okay, how it progresses. Usually, if you see, first, what will happen is your neuro findings will appear. Okay. First, what will appear? The neuro findings will be appearing in an individual first, followed by your hematological findings. Okay. So, if you see, if you see first neurological findings followed by your macrocytosis, which means the cells of the RBCs will be enlarged, because due to B12 deficiency, the normal maturation process which happens in the bone marrow, through which cell size will be reduced as it goes, attains maturation, won't happen. So cell size will be increased, mean corpuscular volume will be increased. Okay, this contributes to high MCV. And retic count, meaning retic count denotes the production of reticulocytes and young RBCs. As maturation itself not happening, new RBCs also not produced due to absence of vitamin B12. So that contributes to low retic count. So also called as hypoproliferative anemia, B12 deficiency. Next, in blood smear, as we know, what will be seen? Hypersegmented neutrophils will be there. Okay. And also, since these RBCs are not all maturing, some RBCs might also rupture. Some cells might also rupture, releasing the cellular enzymes called LDH into the circulation. That will correspond to increased LDH in the circulation. So all these are seen. Treatment. Coming to treatment, if you see, depends on the cause. If it is due to decreased intake, you will be giving 1000 microgram of vitamin B12 intravenously. Okay. That too, you will be giving alternate day will be giving for the first 2 weeks, followed by every monthly for 6 months. Okay, this is the regimen actually you will follow if it is due to decreased intake as in old age. Okay, if the patient is not taking good amount of B12, a vegetarian patient, even in vegetarians, curd is a good source of B12. Even if those set of vegetarians who are not taking curd and they are having macrocytic anemia, those patients you can try IV vitamin B12 alternate day for first 2 weeks and once monthly for the next 6 months. If it then if the cause is due to intrinsic factor deficiency, which carries the vitamin B12, so if that is deficient, which we call it as pernicious anemia, or any gastrectomy procedures have been done, okay, as a component of your sleeve gastrectomy, which is done as a component of your weight loss procedures. So your intrinsic factor producing cells will also be removed. So due to removal of that much of stomach, that will also contribute to B12 deficiency. So there also you should be giving B12. And in chronic pancreatitis also you should be giving B12. Okay. So in these conditions, you will be giving B12 lifelong. And drug-induced, what drug we know? As we know, metformin causes B12 deficiency. If that is there, withhold this metformin and give vitamin B12 to replenish the stores. Okay, this is the treatment protocol of vitamin B12 deficiency. And so now try answering this. All are true regarding SACD of spinal cord except B12 supplement improves the condition. Yes, it does improve the condition, definitely. Columns affected are dorsal lateral. Yes, dorsal column, which is the sensory column, and lateral column, which is the corticospinal tract, which was affected, contributing to LMN in that segment affected, and UMN findings in the segment below. Yes, it is a true statement. Copper deficiency can cause similar findings. Yes, copper deficiency as well as vitamin E deficiency can cause exactly similar picture, similar to our B12 deficiency. So it's always should be in your differential diagnosis whenever you diagnose B12 deficiency. And also, all cases of neuro impairment cannot have macrocytosis because initial manifestation is neurodegeneration, then only followed by your hematological findings. So all cases of neuro impairment can't have macrocytosis. This you should know. Okay. Yes. So thus we read about what all we read. First, we read how is B12 important to your sensory and motor tract, heavily myelinated system, propriosensory ataxia, paresthesia, tingling sensations, and UMN element findings. And then we saw the progression, how it progresses. First, nerve bundles are affected. Then hematological findings. What are the hematological findings we saw? Then how to treat B12 deficiency. We saw it in a nutshell. Okay. Yes. Similar interesting question. We'll meet tomorrow. Thank you.
Good evening. Today's class is about type 3 hypersensitivity reaction. So as you know, type 1 was IgE mediated and type 2 was antibody mediated. But type 3, you have to remember, it is always immune complex mediated reactions. Okay. So when we say immune complex mediated reaction, okay, when we say immune complex mediated reaction, the antigen is already bound to the antibody and it is formed a complex, and this complex is in circulation in the bloodstream, okay, and it goes and deposits in various tissue. Okay, when it deposits in various tissue, it will invite complements. Okay, it will invite complements, especially anaphylatoxins like C3A and C5A, and then it will cause damage to the respective tissues wherever it is planted by neutrophils. Okay, acute inflammatory cells. This is what is the skeleton of what is going to happen. So see, this is from Robbins. So initial step, what happens is there is immune complex formation. In this thing, you have to observe one thing. See, when antigen and antibody, amongst these both, first thing, it should already be exposed. The body should be exposed to that antigen. And the next episode, when it is re-exposed, the antibodies which are already there are going to react with the antigens and form a complex. Okay, that first reaction is immune complex. So whenever there is excess of antibody in the body, it is of no problem because the phagocytes immediately come and they phagocytize the antigen antibody complex. The problem is when the antigens are in excess. Okay, so when antigens are in excess and antigen antibody complexes are not being phagocytized, what happens is in the bloodstream they go and they get planted in various tissues, especially the blood vessels, the renals and the joints. Okay, these three are more prone to it. And then what happens is the complements get activated. Once the immune complex deposition occurs, the complements get activated and acute inflammatory cells like neutrophils come in and they destroy the tissue. Okay, that is blood vessels, okay, renals and joints, which are more prone to it. So when these antibodies are deposited, whenever these antibodies are deposited, they can be deposited in a single tissue like skin, okay, where only the vessels in the skin will be affected, or it can be systemic, so localized or systemic. So both the immune process is going to be the same. It is just that the disease, the reaction is going to be localized or systemic. We will see the example in future. Okay. So these are the things which happens in the pathogenesis of the type 3 hypersensitivity. What is important for us now is the examples, because they're going to ask us about these examples and the questions are going to be directed whether it is type 1, type 2 or type 3 hypersensitivity reaction. Before that, I want to elaborate about acute serum sickness and Arthus reaction. Okay, so acute serum sickness is a condition where when passively immunoglobulin was injected, it was first detected when they were injecting immunoglobulins or antibodies against diphtheria toxins. Okay, when they were injecting antibodies against diphtheria toxins. Okay, so when these globulins were injected, they were forming complex with diphtheria organisms and they were causing acute serum sickness. But nowadays it is common with anti-thymocyte globulin, which is predominantly used in aplastic anemia, graft rejection, anti-snake venom. When we use anti-snake venom. Okay, so if they give you in a clinical scenario, if the patient is suffering from aplastic anemia and was given anti-thymocyte globulin, and the patient presented with fever, urticaria, arthralgia, some hyper sensitivity reaction type profile, you have to think of type 3 hypersensitivity reaction. So this is common with anti-thymocyte globulin nowadays. Previously, it was common with antibodies given to diphtheria toxins. Okay, so that is one thing. So what happens here is when this reaction occurs, that is when it is going to elicit this reaction through complements and acute inflammatory cells, the patient will usually present with fever, urticaria, arthralgia, okay, and for renals, it is proteinuria. Okay, the complements chiefly here which are going to be active is C3A and C5A, which are called the anaphylatoxins. C3A and C5A, which are called the anaphylatoxins. Okay, so when complements are activated and inflammatory cells are recruited, what happens basically is there is increased vascular permeability. Along with this, these neutrophils are going to destroy the blood vessels, leading to fibrinoid type of necrosis. Whenever the blood vessels are necrosed or injury to the blood vessels occur, it is fibrinoid type of necrosis. Okay, so this is acute serum sickness. Very, very important case scenario based questions will be asked. Okay, and then next, one more thing is a localized form of type 3 hypersensitivity reaction is Arthur's reaction. This is an old type of question, but anyways, here the tissue necrosis occurs localized, okay, whenever the immune complex is injected. Fine. Say for example, when you inject antibodies or when you inject some vaccine or anything into the skin, what will happen is that antigen that will initiate the antigen antibody reaction, and local skin vessels, dermal vessels will undergo fibrinoid necrosis, leading to edema, hemorrhage, and ulceration in that specific site. Okay, this is Arthur's reaction. So we'll see a question, we'll see the common diseases, disorders involved, through which the type 3 hypersensitivity reactions are going to occur. Okay, so SLE, very, very important example where the antibodies are going to react against the nuclear antigens, anti-nuclear antibody. And what are the lesions, clinical manifestations? Nephritis, skin lesions, okay, that butterfly skin lesions, arthritis, okay. Then post-streptococcal glomerulonephritis, we have antibodies against the streptococcal cell wall antigens, molecular mimicry, and these antigen antibody complexes are planted in the glomerular basement membrane. That will lead to nephritic syndrome. Polyarteritis nodosa, it is hepatitis B virus antigens, and that will lead to systemic vasculitis, which will show fibrinoid type of necrosis. Reactive arthritis against Yersinia, they will present with acute arthritis. Synovium is affected. Serum sickness, anti-thymocyte globulin, you have to remember, which is used in aplastic anemia, graft rejection, okay. And they will also present with vasculitis, nephritis, and arthritis. Arthur's reaction is cutaneous vasculitis. So these are the important things you have to remember under type 3 hypersensitivity reaction. When coming to the question, a 29-year-old man, age, okay, marked joint pain, presents with marked joint pain beginning 12 days after receiving snake antivenom. So anti-thymocyte globulin or a snake antivenom will initiate type 3 hypersensitivity reaction. I had told you on physical examination, he has diffuse joint pain, arthritis, okay, and his serum creatinine is elevated, okay, and urea nitrogen is upper limit of normal. So this is telling you he has nephritis, okay, nephritic type of syndrome. Microscopic examination of renal biopsy specimen shows focal fibrinoid necrosis of small arterial and arteriolar vascular media. Fibrinoid necrosis of the vessels, be it skin or the renals, it is pointing towards antigen-antibody complex reaction, that is type 3 hypersensitivity reaction. Okay, and there are scattered neutrophil, that is what is going to cause, that is what is causing necrosis. Okay, which of the following laboratory findings in the blood is most likely to be present? So they are asking you what could be the lab finding. CD4 lymphocytosis, no, CD4 lymphocytes have no role in this type 3 hypersensitivity reaction. It has role in type 4 hypersensitivity reaction. Increased IgE is seen in type 1 hypersensitivity reaction. Neutropenia, see here I told you neutrophils are the one which are going to play a major role in tissue destruction. That doesn't mean the this will lead to reduced number of neutrophils. Actually, there is going to be systemic neutrophilia because it's a stimulus for neutrophil recruitment and multiplication. Okay, thrombocytopenia, of course, it is not of any value here. So hypocomplementemia, yes, C3 levels are reduced in this. So that is what, because C3, C5 and all are used up. So hypocomplementemia is the answer. This is a case-based question, very important. The clinching points are arthritis the patient is having, nephritis the patient is having, very pathognomic is fibrinoid necrosis of the vessel, and he has received anti-snake venom. Very, very important. Okay, fine. That's about type 3 hypersensitivity reaction. This table from Robbins, you have to memorize it. Okay, thank you.
Good evening, friends. We'll discuss rickettsia, a very important chapter for your MCQs. So we'll start with the question which has been asked recently. So the question is, a 25-year-old boy went to trekking. He comes with a history of rash and he has undergone few investigation. In that, wheel-philic test shows elevated for OX2 and OX19 titer. What is the most likely organism? So these four options are there: Rickettsia rickettsii, Prowazekii, Rickettsia typhi, and scrub typhus. So the answer is for this question is Rickettsia rickettsii. Okay. So we'll just see the explanation for this. You should be knowing classification of rickettsial fever. What broad group they belong, what are the species in that broad group, what disease is there, what are the vector, and what are the rashes or clinical manifestations. Okay. So we'll start with typhus fever. Typhus fever is caused by Rickettsia prowazekii, and which causes epidemic typhus fever. Endemic typhus fever will be caused by Rickettsia typhi. Epidemic will be caused by louse all over body except palm and sole. So palm and sole will be spared in your epidemic typhus, which is louse-borne. Endemic typhus, which is flea-borne, which is Rickettsia typhi, which mainly will have rashes on the trunk. Okay, so palm, sole, face, if question gets it's spared, your answer should be epidemic typhus, Rickettsia prowazekii. Okay, Now coming to spotted fever. Spotted fever is caused by Rickettsia rickettsii, Connery, or Akari. So coming to Rickettsia rickettsii, which causes Rocky Mountain spotted fever, which is tick-borne, okay? And mainly seen on the extremities, trunk, and it will be hemorrhagic in nature. Connery is Indian tick typhus, which is also tick-borne, and rashes will be present. Okay, Akari, which is called rickettsial pox. Why? Which is vesicular in nature, and it is caused by vector is mite. Rashes will be there, and ischias and lymphadenopathy will be there. Okay. Now coming to scrub typhus. Scrub typhus will be caused by the vector will be trombiculin mite. Please remember which mite? Trombiculin mite, and it is Orientia sushugomasi, and the disease is called scrub typhus. So broad group is scrub typhus group. Disease is also scrub typhus. Vector is mite. Which mite? Trombiculin mite, and species is Orientia sushugomasi, and rashes will be present in this. Fine. Now coming to we'll first finish this slide. Wheel-Felix test. Okay. So first question is, what is Wheel-Felix test? Okay. So what is Wheel-Felix test? It is heterophile agglutination test. Okay. So we know different type of antigen antibody reaction. So it is heterophile agglutination. Heterophile agglutination test. Why we say it as a heterophile? When similar kind of antigen is present in two different species, we say it as a heterophile. Okay. For example, if same antigen is present in human being and same antigen is present in some other plant or animal, that is heterophile antigen. An antibody present against that will cross react with any of that antigen. So plant antigen, which is present in the plant, so antibody will be produced. That antibody can cross react with the same antigen which is present in the human being. So you got my point? Heterophile antigen will be present in two unrelated species, and antibody against these antigens are actually similar, and antibody present against them will cross reacted. So that is heterophile agglutination. So Wheel-Felix is one of the example of heterophile agglutination test. You have other heterophile agglutination tests like Paul-Bunel test and Cole agglutination test. These are other heterophile agglutination test. So why we say Wheel-Felix as a heterophile? Because in this, the antigen, which is rickettsial antigen, the antibody present form against this rickettsial antigen will cross react with the Proteus, non-motile strain of variant of Proteus. Which are those variant of Proteus? OX19, OX2, and OXK. So antibody present form against rickettsia will cross react with Proteus. Okay. Which strain of Proteus? 19, 2, and K. So Wheel-Felix test. So where you see OX19 and 2 positive is Rocky Mountain fever. Now we'll go back to your question. Your question was OX2 and 19. So you got a clue. Patient has history of trekking, right? And rash. Wheel-Felix showed titer of both positive. So your answer should be rickettsia. Rickettsia, which causes Rocky Mountain spotted fever. Now, rickettsial pox will be negative for any of these. Okay. Epidemic typhus will be positive for OX19. Endemic typhus will be also positive for OX19 only. This also has been asked in your NEET entrance. Briel-Zinsser, I will tell you what is Briel-Zinsser. at present we'll know OX19 will be positive for Briell's ulcer. Briell's ulcer is nothing but recrudescence of your rickettsia, your epidemic typhus that is caused by, so nothing, Briell's ulcer is nothing but your recrudescence of epidemic typhus, which is caused by Rickettsia prowazekii. Fine. Okay. So why this recrudescence happens or activation of Rickettsia prowazekii will happen? Because of waning immunity, weakened immunity of the host. Fine. Now, so we are seeing the Weil-Felix test positive for epidemic typhus also, endemic typhus also, and Briell's that is nothing but activation or recrudescence of epidemic typhus. Okay, but will be negative for OX2 and OXK. Now coming to scrub typhus. Scrub typhus will be positive only for OXK. Fine. So OX19 positive, you have 3: epidemic, endemic, and Briell's ulcer, which is epidemic only. Where both 19 and 2 is positive, please remember Rocky Mountain spotted fever. Fine. Where OXK will be positive, scrub typhus. So this tool will help you, this table will help you in diagnosis of rickettsial fever on the basis of Weil-Felix test. So, and we'll go to the question. This question we finished. This table is mandatory. You have to mug up this table. Okay. Now we'll go to next question, which is also based on these table, which we have discussed now. A person is presenting with rashes, except palm and sole, and he doesn't have any history of animal exposure. What is the condition? It is epidemic typhus, rickettsial pox, Rocky Mountain spotted fever, or Q fever. Do you remember the table which I showed? Epidemic typhus, Rickettsia prowazekii, where rashes is present all over the body except palm and sole. Most of the rashes you can see are present on the trunk, but in Rickettsia prowazekii, that is your epidemic typhus, all over the body rashes will be present except palm, sole, and face. So this is the answer for that. Now we'll go on another question. Which of the following is transmitted by vector shown in the image? So what is this vector? This is your trombiculid mite. What is this? This is your trombiculid mite. So do you remember which we discussed in the table which I showed? Okay, scrub typhus, Orientia shushugamasi, right? Trombiculid mite. We'll go back to the table. Scrub typhus, Orientia shushugamasi, and which mite? Trombiculid mite. Okay. So this question was asked in your AIMS 2019 very recently. So you get a picture-based question. So this is one of the examples for those picture-based questions. Okay. Now we'll see what is the vector for KFD, right? What is the vector for KFD? You have vector for KFD is tick. So we exclude this. Orientia shushugamasi, mite, trombiculid mite, which is this. Chandipur virus, for this vector is tick, which is Iodex ticks. Which is also called as deer tick. Okay. Anaplasma is, Chandipura virus is your, Anaplasma is your Iodex tick. Chandipura virus is your sandfly. Okay. So KFD is your arboviral disease. Chandipur virus is your arboviral disease, right? Orientia shushugamasi is rickettsial fever. Anaplasma, which is caused by Iodex tick. Okay. So we'll just discuss a little about scrub typhus, which is caused by Orientia shushugamasi. Mite, trombiculid mite is the vector. Okay. And mite has a larval stage, which is called chigar. So this is called chigarosis. So if you get the chigar, don't get confused. It's nothing but the larval form of trombiculid mite, which causes scrub typhus. Patient will present with fever, cough, GIT symptoms, hepatosplenomegaly, and the complication can be meningitis. Okay. Okay. So few important, we'll just discuss Neal-Moser reaction, which has been asked. What we do in Neal-Moser intraperitoneally when we inject in a male guinea pig, rickettsia, if rickettsia rickettsii, it will cause scrotal necrosis. If it's rickettsia prowazekii, only fever will be present. If rickettsia typhi, conuri, and acri we inject, fever plus positive tunica reaction will be there. That is your inflammation will be there. Okay. Testicular inflammation will be there. So when this is called Neal-Moser reaction, which is question has been asked in previously. So when you inject intraperitoneally in a male guinea pig, rickettsia typhi, conuri, and acri will show fever and testicular inflammation, which is positive tunica reaction, which is called Neal-Moser test. So the question can be asked, positive tunica reaction is seen in, that is your nothing but Neal-Moser reaction indirectly they are asking. Few important point you should know about rickettsia is that it infects mainly the endothelial cells. Okay. Okay. Where they go and infect endothelial cell. Okay. Except rickettsia acri and rickettsia shushugamasi, which causes scrub typhus, these two resides in monocyte. So if it's asked where rickettsia infection mainly resides or it causes, so it is endothelial. Acri and shushugamasi resides in monocytes. Okay. Then question has been asked on drug of choice for rickettsial fever. So drug of choice for rickettsial fever is nothing but your doxycycline. Okay. Okay. So today's class, we discussed about the table, right? All your rickettsia questions are based on those three tables. Please remember those tables. Please mug it up. Okay, those table where we have broad group, we have disease, we have vector, we have clinical manifestation, and which wheel Felix takes OX2 19K, because majority of the question has come on these table. Right, apart from the here there are few question has been asked like your chigarosis, Neal-Moser test, Brill-Zinsser phenomenon, that all has been asked previously. So I conclude today's discussion, which was on rickettsia. Hope the topic was useful for you. Thank you.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education. Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.
So, good evening all for one another session on placental abnormalities. And Like yesterday, we had talked about abnormal separation of placenta. I mean, a separation of a premature separation of a normally located placenta, which we define as abruption. And I had also talked to you about some consequences of abruption to the mother, to the fetus, and we've also talked about etiology of abruption. Why does abruption happen and all that? And today we are going to start studying about the how a typical clinical case scenario of an abruption will be coming in the exam. Okay, so going to today's class. So this is a small question on. This is a small question on abruption. So today I have 3 questions for you. The first question goes like this. Now this is a 34-year-old elderly primate who's on labetalol 100 mg twice daily. So please note all the points. Now I'm going to box all the risk factors for abruption. So we already know preeclampsia as a risk factor, and here it is given. Now she's on labetalol. Okay. Now she delivered a 3.2 kg male baby which cried immediately. After the delivery of the placenta, 200 grams RP clot was delivered. So our yesterday's topic was on RP clot. Okay. Now a diagnosis of abruption was made. What is the severity of abruption as per Page classification? So here we need to study the classification systems which describe the severity of abruption. Is that okay? So we need to talk about severity of abruption and the classification system. So this is a question based on that. And number 2 question is this. Now this is a second gravida, 36 weeks gestation with painful bleeding PV, with painful bleeding, loss of fetal movements, uterus is tense and tender, fetal heart rate is absent. What is the most likely diagnosis? Again, I have boxed all the most important terms. We will come to the diagnosis later on. Okay. Now this is a 32-year-old primate, 34 weeks gestation, presents with again painful bleeding for vagina for the past 2 hours. Vitals are stable. She's not a known case of preeclampsia so far. Ultrasound report says it's a single intrauterine gestation corresponding to 34 weeks in breech presentation. CTG is also non-reassuring. So this is a case of abruption in breech presentation, 34 weeks gestation with a non-reassuring cardiotopogram. How do you manage? So that is what they are trying to ask. So this is a clinical scenario question based on the management of abruption. So this is what we're going to discuss today. And I hope you all know the types of abruption as discussed yesterday. Types of abruption can be concealed abruption. And how it is concealed? The retroplacental clot. And it can be revealed abruption, or we had seen the most common type is mixed. Okay, the most common type is mixed. Okay. Now, when you look at a clinical case scenario for abruption, what are the keywords that you're supposed to look? So now this is really something very, very important. You need to observe all these keywords in the question. Okay. So we will associate it to the pathophysiology of abruption that we have learned yesterday. We know that because of premature separation, there is going to be a retroplacental clot. Fine. Okay. There's going to be a retroplacental clot, and sometimes blood. It's a revealed blood. Okay. It's a revealed hemorrhage. Now this hemorrhage, the typical textbook description, it's dark red in color because the blood stays for some time inside the uterus and comes out a little later. So by the time it comes out, the color of the blood changes. It's going to be dark red in color. Okay, so dark red. And regarding the type of bleeding, it's always painful bleeding. The placenta previa is going to be painless bleeding. In abruption, it is painful bleeding. So please make a note of these 2 keywords. Okay, and here, because of seeping of blood into the layers of the myometrium, now uterus is going to be tense and tender. When you touch, she'll have pain. So tense and tender uterus. Not only that, when the blood gets into the layers of myometrium, the fundal height will increase. Okay, so as the fundal height increases, that point also should be highlighted. Now, what's this? Fundal height more than the period of amenorrhea. So in the question you will see like this, 32 weeks gestation, and then in the description you will see the fundal height is 34 weeks. So then you think you should correlate it like the concealed hemorrhage is more. Is it okay? So fundal height is more than the period of amenorrhea. So these 2 points you should look here. Not only that, so regarding the fetus, you will see features of fetal distress in the question. So definitely, all this I've explained yesterday. So fetal distress, how they'll describe in the question, they'll say that CTG is non-reassuring, or they'll say FHS is abnormal. Okay, and CTG is non-reassuring, or they'll say abnormal fetal heart rate, abnormal FHS, fetal heart rate, or they'll tell you it is meconium staining of liquor sometimes. Okay, meconium staining of liquor. See, sometimes this blood also gets into the amniotic cavity, and then the liquor also may be blood stained. So question will say sometimes ARM done, artificial rupture of membranes done, and we have seen a blood stained liquor. Okay, so please make a note of all these keywords. Okay, and blood stained liquor. Okay. So this is not only this. In addition to this, what you're supposed to see is recollect all the risk factors that we have learned yesterday. Okay, all those risk factors that we have learned yesterday. So in history, you might see elderly, not always. Okay, multi also not always. These two goes in favor of abruption, but otherwise, if you see a young woman who's a priming, then it doesn't mean you should exclude the possibility of an abruption. So please keep that point also in your mind. Okay, and in history, the most important predominant factor that you'll see is preeclampsia. I told you yesterday itself, abruption can be grouped into two different types, like abruption, which is because of preeclampsia or chronic hypertension, which occurs in the background of hypertension. Abruption is not there in the background of hypertension. So preeclampsia, chronic hypertension. Sometimes you will have APLA syndrome, which is also a very important cause for abruption. So you have to look for this. I also told you that another very important cause for abruption is abdominal trauma. And trauma can be like she had a history of fall, or it was a case of road traffic accident. And I already told you, you will find something like domestic violence and domestic abuse also you will find in the question. So a history of trauma. Okay, or you will find history of procedures telling this has occurred following external cephalic version. Okay, so sometimes you will get procedures also in the question. So following external cephalic version, the heart has become abnormal and the patient had symptoms of bleeding, TB, which was painful, dark red blood, and uterus is tense, tender, all that you will get in the question. Is it okay? Sometimes substance abuse, and we have seen smoking is very, very important link to abruption. Not only abruption, also to placenta previa. See, cocaine abuse is something which is linked very much to abruption. So you will find all this in the history. Okay, so that's it. So these are the keywords. Please make a note of this. I repeat, you will be seeing dark red bleeding, painful bleeding, tense and tender uterus, fundal height more than the period of amenorrhea, ARM done, and they'll say it's blood stained liquor, and commenting on the fetal heart. Sometimes fetal heart may be normal, the severity of abruption is less, but otherwise if the bleeding has been profuse, then fetus will go for compromise. You will see either of the three, CTG non-reassuring, or they will say FHR is abnormal, some things like that. Background history, you will see a woman with preeclampsia, history of trauma, procedures, or something like this, smoking and cocaine abuse. So you will see the wholesome scenario will be like this. So severity of abruption is described by a lot of classification systems, and here there are mainly two classification systems. One is Page classification system and the other is Shep classification system. And I'm going to talk to you only about Page classification system because this is all the time told in our standard textbooks. Okay, so Page system we have 0, 1, 2, and 3. So don't forget this number 0. Okay, what does a 0 mean? See, in fact, it's not APH. It's not a bleeding before the delivery of the baby. It is only after the delivery of the fetus you find RP clots. So in the question you have only RP clots. Everything else was normal. No fetal compromise, no maternal compromise, nothing. Only after delivery you find RP clots. So what is grade 1? Grade 1 is just antepartum hemorrhage. Woman presents with hemorrhage before delivery of the baby. There's absolutely no fetal compromise, no maternal compromise. So grade 2 is APH plus a fetal compromise. APH plus fetal compromise. Because see, we had already had a question on Page system. Yes or no? So we'll go back and do that question now. What is 3? Now this is APH plus maternal compromise. So maternal compromise, yesterday I had told you all the complications. What all complications can occur to the mother? It can be shock. So if in the question if you see shock and then she was resuscitated, then you should write page 3, okay? Or it can be renal failure, acute renal failure and DIC. So usually we have a small mnemonic to remember. It is sad to see abruption happening. So shock, ARF and DIC. Okay? So these 3 complications can also lead to, any of the complications can lead to maternal death. Okay. So if it said it is this abruption has gone in for DIC and DIC was corrected, then you should put that abruption into page 3. Is it okay? So this is all about the severity of abruption. Now I'm going to talk to you about how we're going to correlate. This is a question which has already come in the exams, and in this question we are going to find out all the positive points regarding abruption. Okay, so 37-year-old, so 37 years, elderly is a risk factor for abruption. Then look at the second point, primary gravida woman comes. So primary gravida, is it a risk factor for abruption? No. Okay, so we will strike this off. This is how you should read questions. You should never try to memorize only facts. If you memorize like that, you will not be able to remember all those in the exam. You should try to correlate it with the questions and scenarios. Okay? Now she comes to the emergency room with constant and severe abdominal pain that is accompanied by severe vaginal bleeding. So here it is painful bleeding. So question describes painful bleeding. So we will mark that point also. Okay. Now this has been occurring for the past 3 hours and the patient is very concerned. She is 37 weeks pregnant. Her blood pressure is 158 to 102. So that means background of preeclampsia. And her pulse rate is 120 per minute. Now this says she is not hemodynamically stable. Okay. Her physical examination shows a firm, distended, tender uterus. So please, so distended uterus means the uterus is more than the period of amenorrhea. So here this goes in favor of concealed APH. So in addition to this bleeding that is externally seen, she also has concealed APH. Now a speculum examination shows 80 ml of dark red blood in the vagina. See, again we have here positive points for dark red blood. So this also goes in favor of abruption. Now a moderate amount of blood is also observed coming from the cervical os. It's okay. Fetal heart rate monitoring shows baseline heart rate of 105, no variability. Baseline heart rate is also abnormal, no variability. So this is an abruption which has led to fetal compromise. Okay. What is the most likely cause of the patient's bleeding? So we can immediately readily come to a conclusion that this antepartum hemorrhage is because of premature separation of placenta, which is abruption. Okay, we have lots of positive factors: history of preeclampsia and dark red blood. Okay, tense uterus, tender uterus, and which this abruption has led to fetal compromise. So lots of things. So here the questions are: number 1, what is the page classification here? Because it has led to fetal compromise, we can definitely put the page classification as 2. But currently, mother is not very unstable. Her pulse rate is 120, but other things regarding the maternal shock is not that much given. Okay, BP is still getting maintained. She's not gone to a stage of hypotension, so maybe we leave off that. We'll take this is fetal compromise, and we'll classify this as page 2. Okay, so this is question number 1. Okay, so this is definitely abruption. We do not have any doubts about it. What could have been the etiology for abruption? Could have been due to preeclampsia. Okay, that could have been the etiology. Her elderly age and the preeclampsia are the main etiology here. So I think we'll go back to questions. So today I have taught you how a typical clinical case scenario of abruption will present and what are the keywords that will come in a question with abruption. Okay, so I think we'll go back to questions and finish off the questions. And in next class, I'll be talking to you about management protocol for abruption. Okay, so see elderly primary. Okay, elderly is a risk factor for abruption. She is on labetalol 100 mg twice daily, and she delivered a 3.2 kg male baby. Cried immediately, so no fetal compromise. After delivery of placenta, 200 grams of RP clot was delivered. So what is it really? So that means this woman had never presented with an antepartum hemorrhage at all. Only after delivery we are seeing the presence of retroplacental clot. So this comes under grade 0 abruption. Okay, now going to question number 2. This is a 36-week second gravida. painful bleeding PV, loss of fetal movements, uterus is tense and tender, cephalic presentation, fetal heart rate absent. What is the most likely diagnosis? So this is very simple, abruption. So how do we rule out the other things? Placenta previa, why should the uterus be tense and tender? And in placenta previa, it's mainly painless bleeding. It's mainly painless bleeding. Okay. And preterm labor, why should she have tense and tender uterus? So preterm labor also will exclude. Placenta previa also will exclude. Rupture uterus, what is the reason for spontaneous rupture? Okay. And moreover, in rupture uterus, once the uterus is ruptured, she will have loss of contractions. So she will have loss of sudden cessation of pain. Okay, sudden cessation of pain. It's clearly given in the question. It is painful bleeding. So we are not in favor of rupture uterus also. Okay. And we will have on PV receding of the presenting part. We will not be able to feel the presenting part. Receding of presenting part. So for this question, the answer is C. So I think for the next question, which we have, which is a clinical case scenario question on abruption, we will do it in the next class when I teach you the management protocol for abruption. And we'll also make a table differentiation between abruption and placenta previa. So thank you all for your patient listening. Meet you again in the next class.
Yeah, good evening, everybody. So we'll continue with the autonomic nervous system. So today's topic will be on anticholinergics. Yesterday we saw cholinergics. Today we'll see anticholinergics. So coming to anticholinergics. We have drugs by special mechanisms, receptor selective antagonist, non-selective antagonist. There are only three categories. One is drugs by special mechanism. Second one is receptor selective. Third is non-selective. Drugs by special mechanisms, we have already seen it. Choline uptake is inhibited by hemicholinum. Vesicular uptake of acetylcholine is inhibited by vesamicol. And exocytosis step is inhibited by botulinum toxin. First class also we saw, second class also we have revised it with the MCQ. For receptor selective antagonist, we have M1 blockers, M2 blockers, M3 blockers. Okay. This M2 blocker is not that very commonly used. So we need not bother about this much. We should be more concerned about the M1 blocker and M3. M1 blocker also nowadays they don't use it. But M3 blockers is very, very important from exam point of view. M3 blockers. Okay, we'll discuss in detail. With respect to non-selective antagonist, we have our common drug that is atropine and hyoscine. Okay. So now coming to atropine first. See, atropine is a CNS stimulant, whereas scopolamine is a CNS depressant. That's the difference between atropine and scopolamine. You should remember this. That is hyoscine and atropine. Okay. This scopolamine can be used as a lie detector because it causes twilight sleep. You know, first class only I have told routes of administration. Transdermal patch is used in motion sickness, drug of choice. Whereas for mountain sickness, drug of choice is acetosolamide, carbonic anhydrase inhibitor. Central anticholinergics. We'll just see atropine and then come to central anticholinergics. So what is the action of atropine in eye? Atropine, homatropine, cyclopentolate, and tropicamide. There are 4 drugs in this group. Atropine, homatropine, cyclopentolate, and tropicamide. So what is the use? It is a mydriatic. Of course, M receptors in the ciliary muscles has gone. Even circular muscles of iris will also be inhibited. So there is no parasympathetic stimulation because this is parasympathetic lytic. So it causes mydriasis. Cycloplegic agents. Cycloplegia. Where is cycloplegia useful? Cycloplegia is useful in when you want to check for refractive errors. It is useful. Even in atropine can be used in uveitis, iriitis, all those where there is a spasm of ciliary muscles. To relieve the spasm, atropine can be given. What is the main feature of atropine is it's a long duration of action, 3 to 5 days. 3 to 5 days. So it is avoided in adults because patient can't see clearly because of long action. Cycloplegia will happen. So driving is not possible. Okay. So we should not use atropine in adults. Coming to hyoscine. Similar to atropine in cycloplegia, the cycloplegic effect is similar to atropine, but it's more potent mydriatic. It is more potent mydriatic. Okay. Tropicamide. Shortest acting mydriatic available in market. Remember this, tropicamide is the shortest acting mydriatic available in the market. Okay. All these parasympatholytics, atropine, homatropine, tropicamide are contraindicated in glaucoma because it can cause mydriasis. It is contraindicated in glaucoma. Okay. In CVS, the main effect is tachycardia because of postsynaptic M2 receptor inhibition. In the eye, it is M3. In the heart, it is M2. But initially, it might cause bradycardia. Initially, it can cause bradycardia because of presynaptic. Okay. But this is not very important. Some textbooks have given this, so they might ask in exam. That's why I'm telling you. You will not have this in mind initially. Tachycardia is the predominant effect. That is because of postsynaptic M2 inhibition. It is used where? It is used for digitalis-induced bradycardia. Remember this. It is used in treatment of digitalis-induced bradycardia. Also in AV block. Yeah, AV block, acetylcholine will be more AV block. So you can give atropine there. Very good point here is no effect on blood pressure and contractility. Remember this, atropine does not have any effect on BP and contractility. It is only altering your rate. Okay. Now, going to central anticholinergics. Trihexyphenidyl, there is nothing but benzhexol, benztropine, and bipyridine. 3 Bs. Remember this. 3 Bs, blood-brain barrier. 3 Bs. Benzhexol, benztropine, and bipyridine. They are used for drug-induced Parkinson's. They might ask you in MCQ. They usually ask this. Among the following, which can be used for drug-induced Parkinson's? They can give a scenario. A patient on Parkinsonism was given so-and-so, levodopa, all these drugs. The patient developed Parkinsonism, or some drugs that can cause Parkinsonism they might give, and they develop drug-induced Parkinsonism. What is the treatment of choice? We have to check benzhexol, bipyridine, and benztropine. Okay. So this is over. Now coming to respiratory system for atropine. Bronchodilation. Yes, it is used as a bronchodilation because of M3 antagonism. Okay. There are 4 drugs in this class. First is ipratropium, tiotropium, umeclinidium, and refifenacin. This is a new drug, refifenacin. This tiotropium is selective for M1 and M2. Okay. Tiotropium is selective for M1 and M2, whereas this ipratropium is non-selective. So now let's go back to the earlier presentation of ANS. Now you will understand it better. See this. M3 receptors present in the bronchus. M3 receptors are present in the bronchus. So now coming back to your current presentation. So this we will change it to M3. Okay, remember this. Why I have put it as M1 and M2 is just to make sure that you understand it. In exams, they might ask this. That's why I put the wrong one first. Make sure go to the previous slide, what I have discussed in my class, and then come back to this slide. So remember this, tiotropium is selective for M3. Okay, whereas ipratropium is non-selective. Among this, ipratropium is short-acting. Okay, usually this class of drugs, ipratropium, tiotropium, umeclinidium, refifenacin, all are used in COPD. But where it is used in asthma? What is the use in asthma? With steroids, you can use for long-term prophylaxis sometimes. With steroids, you can use for long-term prophylaxis. One more thing, when an asthmatic is already on a beta blocker treatment, the beta agonist will not work. Salbutamol won't work because the beta blocker is already being given. In that case, this group of drug will become the bronchodilation of choice. Other than ipratropium, tiotropium, umeclinidium, and refifenacin are all long-acting. Okay, all are available in only one form, inhalational formulation. One more drug that can be remembered here is glycopyrrolate. It's a pre-anesthetic. It reduces the secretions and prevents reflex bronchospasm. So whenever you intubate the patient or when you give anesthesia, there might be an increase in secretions. During intubation, there might be bronchospasm, severe reflex bronchospasm. To prevent that, you can give glycopyrrolate before the anesthesia is started. Coming to GIT, everything is decreased. Very simple. Tone is decreased, motility is decreased, secretions is also decreased. I told you M1 blocker. This is present in the M1 receptors are present in GIT, ganglia. M3 is present in glands. So this mainly attacks the ganglia, pyrancypine and telancypine. It is used for peptic ulcer. But now it is not used because anticholinergic side effects are more, so they are not used. You have iosine, dicyclomine, both these are used. This is not that commonly used, propanthelin and oxyphenonium. Whereas iosine and dicyclomine are commonly used, it is used as an antispasmodic because it decreases tone motility. It can be used for intestinal colic. Okay. Recently, I had one patient in my clinic. So when I saw the patient was complaining of intestinal colic, so I gave him dicyclomine. Not really. Okay, he's fine. So it can be used in treatment of intestinal colic. M3 blockers, darifenacin and sulfenacin, mainly these are vesicoselective. Actually, this is vesicoselective. But since it is M3, it can be also used for irritable bowel syndrome. It can also be used for irritable bowel syndrome. But it can be asked, this new question can be asked based out of this. This M3 is also present in your GI tract. This darifenacin and sulfenacin is mainly a vesicoselective anticholinergic, but still they have now tried it on irritable bowel syndrome and they are using it. Off-label use. So they might ask this in MCQ. Okay. Genitourinary tract, it decreases the motility. Correct. Urinary retention occurs. Not to use in benign prostatic hyperplasia. Okay. So it decreases the motility. Urinary retention occurs. Dicyclomine, flavoxate, oxybutonium. There are different drugs. Among this, first group we will see is M3 selectives. Trospium, tolterodine. Festolterodine is nothing but a prodrug of tolterodine. Festolterodine is nothing but, festoridine is nothing but prodrug of tolterodine. Trospium, tolterodine. Festirodine, that is a prodrug of tolterodine. Darifenacin, sulfenacin. These are vesicoselective M3 antagonists. So this is useful in the treatment of urinary incontinence. Nothing but it makes the bladder soft. It makes bladder soft. It is used in urinary incontinence. Okay. Other than this, you can use dicyclomine, flavoxate, and oxybutynine. There are three more drugs. Dicyclomine, flavoxate, and oxybutynine. This can also be used in treatment of urinary incontinence or renal colic because antispasmodic effect is there. But mainly we are concerned about this M3 antagonists, vesicoselective. Oxybutynin can cause dry mouth. It is shortest acting. Trospium, it has minimum CNS penetration. Remember, trospium has minimum CNS penetration. So this can be used in patients with urinary incontinence in Alzheimer's disease. Even this vesicoselective antagonist can also be used because they don't cross the, even though they cross the blood-brain barrier, there is no M3 receptors. They don't act in the brain. They act only in the bladder. It is not metabolized by liver, this trospium. Solifenacin is longest. So oxybutynin is shortest. Solifenacin is longest. Oxybutynin causes dry mouth. Mirabegron, Vapegron, we already know B3 receptor stimulation. This can also be used for overactive bladder. It's a sympathomimetic. Glands, it decreases the secretions. Atropine can cause hyperthermia due to decreased sweating in children because hyperthermia, sweat glands are M3 cholinergic sympathetic. Okay, so do not give atropine in child. It can cause hyperthermia. Be very careful. Now coming to oxobotulinum toxin, toxin A, onabotulinum toxin A is used to prevent headache in chronic migraines. Parabotulinum toxin A is used in glabellar lines. IM for glabellar lines, intramuscularly for glabellar lines. Botulinum toxin type A, type B is there. Type B only for cervical dystonia. Strabismus, blepharospasm, cervical dystonia, and glabellar lines. So these two questions we can see tomorrow due to lack of time. And we will have a quick revision also about this botulinum toxin. Remember this, botulinum toxin, onabotulinum toxin A, prabotulinum toxin A, IM for glabellar lines, onabotulinum toxin A for migraines, chronic migraines, type A, type B botulinum toxin for strabismus, blepharospasm, cervical dystonia, and glabellar lines, whereas type B only for cervical dystonia. Even intra-bladder injection of botulinum toxin can also be given for overactive bladder. Two questions are there. We will see it tomorrow before the start of the class because of time, lack of time. Okay, thank you.
Yeah, so good evening. So today we'll be discussing about the visual field effects. So this, we have got two questions already in the last AIMS and also in the last INI-CET. So we got a defect on the, in case of an optic tract lesion, they asked in the previous NEET, and in the previous INI-CET, they asked in case the bite homonymous hemianopia. Okay, so we'll be discussing this in detail. Okay, so you should remember that the visual pathway starts from the optic nerve and ends in the occipital cortex. So any lesion along the pathway will produce a visual field defect. The most important point about the visual field defect in case of a compressive or a traumatic lesion or a neurological lesion is it respects the vertical meridian. It respects the vertical meridian. Okay, so any pathology arising from the optic nerve to the occipital lobe will respect the vertical meridian. Okay, so that is one very important point we have to remember. So this also will help you differentiate if it is due to a compressive lesion or if it is a pathology like an AION, which respects the horizontal meridian. Okay, so if it is an ipsilateral optic nerve lesion, the patient will have an ipsilateral monoocular vision loss. So on that side of this one, the patient will have an ipsilateral monoocular vision loss. Next, if the patient has a lesion of the optic chiasma, we know that there is crossing over of the nasal fibers. So 53% of the nasal fibers cross over at the optic chiasma and the 47% of the temporal fibers pass uncrossed. So because of the crossing over of the nasal fibers, we get a bitemporal hemianopia in case of a optic chiasma lesion. Okay, so they can also ask you which lesions produce a binasal hemianopia. So which lesion produces a binasal hemianopia? So binasal hemianopia can be produced by any compressive lesion on the lateral part of the optic chiasma. Okay, so any lesion which compresses on the lateral part of the optic chiasma, typically it is a bilateral internal carotid artery aneurysm. Bilateral internal carotid artery aneurysm typically compresses the temporal fibers, resulting in a binasal hemianopia. This results in a binasal hemianopia. Next, from the optic tract, So what happens if it is an optic tract lesion? So the ipsilateral temporal nerve fibers and the contralateral nasal nerve fibers are lost. So because of which we'll have a contralateral homonymous hemianopia. What is a homonymous hemianopia? Homonymous hemianopia is if the nasal side on one side and the corresponding homonymous side on the other side, that is the temporal side on the other side is involved, it is a homonymous hemianopia. So optic tract lesion will result in a contralateral homonymous hemianopia. So any lesion beyond the optic tract, remember, it will result in a homonymous hemianopia. Very important point. Any lesion beyond the optic tract will result in a homonymous hemianopia. That is nasal side on one side and temporal side on the opposite side, on the contralateral side. Okay. So this is the optic tract lesion. Next, we have the lesion of the upper optic radiation. So from the optic tract, we have the upper optic radiations and the lower optic radiation. The upper optic radiation passes through the parietal lobe. The upper optic radiation passes through the parietal lobe. It typically results in the pi in the floor appearance. This is the pi in the floor appearance. Pi in the floor appearance is due to the upper parietal optic radiation fibers. Because of the lower temporal optic radiation fibers, also known as the Meyer's loop, you'll have a superior quadrantanopia. Presence of a temporal optic radiation fibers involvement or the involvement of the Meyer's loop will result in a superior quadrantanopia. So previous aims, we got the Meyer's loop involvement resulting in a superior quadrantanopia. Prior to that, we got the optic tract lesion. So remember, optic tract will result in a contralateral homonymous hemianopia. Next, whenever the lesion is involving the occipital cortex, whenever there is involvement of the occipital cortex, remember it results in a contralateral homonymous hemianopia. Typically, there is macular sparing. So they can ask you, why is the macular sparing in an occipital lobe lesion? Okay, so how do you differentiate an optic tract lesion from an optic lobe occipital cortex lesion? In an occipital cortex lesion, the patient will have a macular sparing. The macular sparing here is because of the bilateral blood supply. There is a blood supply from the middle cerebral and the posterior cerebral artery. Okay, it is a watershed area receiving blood supply from both the middle cerebral and posterior cerebral artery. Hence, in case of an occipital lobe involvement, there is a macular sparing. It is a homonymous hemianopia with a macular sparing. This is your visual pathway. Okay, so next important they'll ask you is lesions of the optic chiasma. So if the lesion is compressing the optic chiasma from above, what is the presentation? And if the lesion is compressing the optic chiasma from below, what is the presentation? So this is very important. So this helps us to differentiate between the pituitary adenomas and the craniopharyngiomas. So how does the pituitary adenoma spread? So typically the pituitary adenoma spreads from below the pituitary adenoma. So this is the sella turcica. So on the sella turcica, we have the pituitary gland. So tumor of the pituitary gland or the pituitary adenoma, it compresses the inferior fibers first. So the inferior fibers, typically they supply the superior quadrant. So this will result in a descending type of a visual field defect. Descending type of a visual field defect. Okay, so if a tumor spreads from down from above, okay, if it spreads down from above, so what happens? The inferior fibers are superior fibers are involved first. So this will result in an inferior quadrantanopia. So it is an ascending type of a bitemporal hemianopia. So very important. Remember, a pituitary adenoma will result in a descending type, whereas a craniopharyngioma will result in an ascending type of a bitemporal hemianopia. This they have asked, and this you will get a question in the future also. Okay. So next, another important scotoma known as the junctional scotoma of the trachea. What is junctional scotoma of trachea? So what did I tell you? The nasal fibers cross over at the optic chiasma and reach the opposite side. So whenever there is a compression at the junction of the optic nerve and the optic chiasma, when there's a compression at the junction of the optic nerve and optic chiasma, what will happen? The patient will have an ipsilateral central visual field defect. Because of the compression of the optic nerve, the patient will have an ipsilateral central visual field defect, and he will have a contralateral temporal field defect. So the contralateral temporal field defect is because of the nasal fibers which cross over from the opposite side. So this is known as the junctional scotoma of trachea. Junctional scotoma of trachea is because of the compressive lesion between the optic nerve and the optic chiasma. So this you can get a question. Okay, so what did I tell you? I told you the Any neurological compressive lesion will respect the vertical meridian. The only pathology which respects the horizontal meridian is the AION. So remember, the AION, the anterior ischemic optic neuropathy, typically will produce an inferior field defect, which is also known as the altitudinal field defect. Altitudinal field defect. Okay, so this altitudinal field defect will always respect the horizontal meridian. It will always respect the horizontal meridian. Typically, the patient will have so we have the ischemic type and the non-ischemic type. The ischemic type, also known as the anterior ischemic optic neuropathy, is associated with anterior ischemic type of an anterior ischemic optic neuropathy is typically associated with giant cell arteritis. Typically seen in elderly females. They have a temporal swelling. They have pain during combing the hair. If you do an ESR, it is typically raised. Okay. The diagnosis of choice for a giant cell arteritis is a full thickness temporal biopsy. So this also they have asked. Okay. So full thickness temporal biopsy will show the inflammation of all the 3 layers of the blood vessel. In case of a giant cell arteritis, the patient will have a altitudinal field defect which respects the horizontal meridian. So this, what is this? What do we see here? So we see we see a compressive lesion on the frontal lobe. So the compressive lesion on the frontal lobe typically results in an ipsilateral optic atrophy and a contralateral disc swelling or papilledema. Okay. So ipsilateral optic atrophy with a contralateral disc edema is known as the Foster-Kennedy syndrome. So Foster-Kennedy syndrome. Okay. This is the Foster-Kennedy syndrome. So quickly coming to the questions, the optic tract lesion on the left side manifests as, okay. So optic tract, this is the previous INI-CT question. So left optic tract lesion will result in a right-sided homonymous hemianopia. So remember, any lesion beyond the optic tract will result in a contralateral homonymous hemianopia. So left lesion, right-sided homonymous hemianopia, okay. So this we just discussed. So arterial blood supply of the visual cortex. So remember, the blood supply of the visual cortex is from the posterolateral branch of the posterior cerebral artery. I told you the macula receives dual blood supply from the middle cerebral and the posterior cerebral artery. It is the watershed area. Okay. So this posterolateral branch supplies the occipital cortex. So diagnose the condition. So just now we discussed tumor of the frontal lobe compressing, resulting in ipsilateral optic atrophy and a contralateral papilledema, which is known as the Foster-Kennedy syndrome. Next, we have a patient who has a right-sided homonymous hemianopia with a saccadic pursuit movements and a defective optokinetic nystagmus. Okay, what is optokinetic nystagmus? Optokinetic nystagmus is a physiological nystagmus. Remember, it is a physiological nystagmus. It is a function of the parietal lobe. Okay, and parietal lobe lesion, what did I tell you? A parietal lobe lesion will result in a contralateral, it will result in a contralateral homonymous hemianopia. Typically it is an inferior quadrantenopia. Typically it results in an inferior quadrantenopia. So remember, optokinetic nystagmus is a physiological nystagmus because of a lesion in the parietal lobe. Lesion of the Meyer's lobe or the temporal lobe will result in a superior quadrantenopia or pie in the sky. Lesion of the optic radiation involving the Meyer's loop, it results in a superior quadrantenopia or pie in the sky. So just now we discussed pie in the sky and pie in the floor. So left-sided lateral gaze is affected in the lesion of, okay. So lateral gaze, what is the, what did I tell you? The cortical control of the horizontal gaze is via the frontal lobe, mainly the contralateral frontal lobe. So the patient here, the answer will be right-sided frontal lobe. So the horizontal gaze center is the PPRF, which is under the direct control of the contralateral frontal lobe. So here we have a patient with the left-sided lateral gaze. The answer is a right-sided frontal lobe. Okay. The center for the lateral gaze is the ipsilateral PPRF, which is under the direct control of the contralateral frontal lobe. Okay. So with this, we finish the questions. Okay, hopefully it's useful. This is a very important topic what we discussed today. So kindly go through the presentation. Thank you.
Hello, am I audible? Okay. Hello, everyone. I'm Dr. Sneha, and today we'll be discussing a little bit on the topic of induction of labor. Again, this is one of the questions that was asked in the recent INICET, and also progressively we've been seeing that in many of the entrance exams, a lot of topics involving from the labor, the topic of labor, different subheadings under labor seems to be a favorite in many of the competitive exams. So when you think about labor, there are two ways in which a woman can come in labor. The first is called spontaneous because of the various physiological cascade of hormones that occurs in the baby and the mother's body. It results in natural or spontaneous onset of contractions in the uterus. And because of this contraction, the cervix slowly starts dilating and the baby is born. Ideally, this is how we would want every woman to deliver because spontaneous onset of labor is associated with a very high rate of normal vaginal delivery and less amount of complications such as fetal distress or any other complications to the mother. Sometimes what happens is that we cannot wait for the mother. We do not know when a patient will go into spontaneous labor. You might have seen many times the patient will ask, when will I start having pain or when will I go into labor? There is absolutely no way of telling her or finding out. But you can give her time to go into spontaneous labor if the patient has no complications. Sometimes what happens is that she might have some complications. The mother or the baby might have some complications, and you do not have the luxury to give her the time for her to spontaneously start her labor. Let's take gestational hypertension, for example. Suppose the mother has gestational hypertension and say that she wants to wait till she gets into labor. It is shown from studies that if you wait in gestational hypertension at more than 39 weeks, there is a high chance for the baby to have complications like fetal distress, or there can be abruption, or there can be eclampsia. So to avoid all these kind of complications, we artificially start labor. So induction of labor means we artificially start the process of labor. We try to mimic what naturally happens in a woman's body, but at an earlier date, before she goes into natural labor, because of various indications, either maternal or fetal. Okay, this is just an example. You're trying to avoid the complications that can occur because of this comorbid condition by artificially starting labor before she goes into natural labor. Now, what does induction of labor involve? What happens naturally in a woman's body by different hormonal cascade? You're trying to mimic it by giving her various pharmacological or physical substances, mechanical substances. So there are two main components. One, this substance should bring about cervical changes, because only when the cervix shortens and dilates, the baby's head can be delivered through it. Second, and the more important component will be the uterine contractions, because without contractions, again, it is not possible to have labor mechanisms. Let's look at it one by one. In cervical changes, there are two main components that we are going to see. The first is dilatation, which means opening up of the cervix. Usually before labor and any gynecological cervix, the cervix will be closed. It will be a pinpoint or a longitudinal slit-like structure in multiparous, pinpoint in nulliparous. This cervix will slowly start dilating. In fact, it has to dilate up to 10 centimeters to allow the baby's head to be born. The second is, and a little more difficult thing to understand, is what we called as effacement. Effacement, in another word, means that shortening of the cervix. Cervix is a tubular structure. Now, in this picture, you can see that the cervix is a long tubular structure and this is the os, and the os is closed, isn't it? As the labor progresses, you can see that the length of cervix is gradually decreasing, and at one point there is no length at all. The cervix becomes a thin structure. And similar way, the cervical os is dilating slowly and it is opening up more and more as the labor progresses. Okay, so this is what I mean by effacement. There is shortening of the cervix and a thick tubular cervix slowly becomes papery thin. This is what we mean by effacement. To put it even more simple, imagine in pre-labor cervix is something like a green mango where it is quite hard. But as the cervix starts becoming favorable, it becomes more like the ripened yellow mango, which is very soft and it can be easily dilated and it can easily shorten. Okay, so that's why we call this process as ripening of cervix. Uterine contraction is needed to push the fetus down and also to cause cervical dilatation. So through induction of labor, you need to bring about these two mechanisms, which will normally happen in a woman's body, but when you're trying to do it by artificial methods. Let's look at an MCQ. What is the IOL agent that is shown in this picture? So now you see a band-like structure here, which is supported by a long thread. Okay, your options are misoprostol, dinoprostone insert, dinoprostone gel, or Foley's catheter. All of these are different inducing agents. Now the answer here is dinoprostone insert. Okay, you insert this whole thing in the posterior fornix. Misoprostol is a form of tablets. And dinoprostone gel will be like it will be in a cylindrical container. I'll be showing in the next picture. And Foley's catheter, you all must have seen. It's an orange color bulb-like structure with a long tube. Okay. So let's look at some of the induction agents that is commonly used to ripen the cervix. Broadly, there are three different types. First is the natural method called sweeping of membrane. Second is the pharmacological methods, and third is the mechanical method. Sweeping of membrane is where you insert the finger between this thin blue color structure is the amnion. Okay, so insert the finger between the amniotic membrane and the patient's into the cervix, into the uterus, in the lower segment, and you strip the membrane. You strip the amniotic membrane. Usually the amniotic membrane will be in close contact with the inner uterine substance or the decidua. What you do is that you put the finger inside to separate or to create a space between this amniotic membrane and the decidua underneath. What happens is that this releases PGF2 alpha. Okay, and this can produce contractions of the uterus. Now, the main advantage is that this is one of the natural methods, and usually there will be no side effects involved because you're just sweeping the membranes or stretching the membranes, okay? But if you do it very forcefully, it might lead to rupture of membranes. But the downside of this is that suppose if you do it today, you do not know when the patient will go into labor. It is unpredictable. She might start having contractions today. She might have starting contractions a week later. She might not even start having contractions. So it is an elective procedure or in non-urgent cases. For example, a patient comes at 39 to 40 weeks and you do a pervaginal examination to see if the cervix is favorable in a low-risk patient, and you do a sweeping of membrane so that she goes into labor soon. Such kind of scenario, you use sweeping of membrane. What about pharmacological method? The first is the misoprostol tablets, otherwise called as PGE1. Okay, and these are in tablet forms. And this can be given either as per oral or per vaginal. Per vaginal means usually you put it in the posterior fornix. Okay. Usually the dose that is used in term patient is 50 microgram or 25 microgram, and you repeat it every 4 to 6 hours. Okay, maximum even up to 6 times you can use. All right, so this is about misoprostol. Second is the gel, dinoprostone gel, otherwise the pharmacological component is PGE2. This is a cylinder that contains the gel in this part, and if you open this cap, there will be a plastic cannula like thing, and if you insert the piston and push, the gel will be slowly released into the vagina. So there are two methods. One is called intracervical method, where you directly put the gel into the cervical canal, or intravaginal method, where you insert the gel in the posterior fornix. Recent studies have shown that this might be a better way, because by putting it directly into the cervix, it can cause exaggerated response. Okay. The dose is usually 0.5 mg, and you can repeat it every 6 hours for maximum of 3 doses. All right. And the last method is the picture that we saw. This is also dinoprostone, otherwise called as PGE2. And this small part, this bulged portion, contains 10 milligram of PGE2. The advantage is that you insert it once, you can leave it inside for 12 to 24 hours for it to start having action. You don't have to keep doing per vaginal examination every 4 to 6 hours like the first two methods. You put it inside and you can ask the lady to move around and she can be comfortable. And within 12 to 24 hours, you expect the changes in the cervix to start happening. So that's, you put it inside and then you leave it. That's the advantage of this, okay? So this is PGE2 insert. These are some of the pharmacological methods that are available right now. What about mechanical method? The first mechanical method is the Foley's catheter. Or in this picture, it is a double, there are two bulbs, okay? One which is inserted into the cervix and one in the vagina. Whereas in Foley's catheter, there will be just one bulb that will be inserted inside. And when you put the fluid inside the Foley's bulb will expand, and this will mechanically cause dilatation of the cervix, right? So that's how it acts. The second method is called as a laminaria tent. Laminaria tent is a type of seaweed. Usually it looks like this, okay? And there's a thread attached to the end of it so that we can easily remove it whenever required. When you put this into the cervical canal, it will start absorbing moisture from around it and it will swell up like this. Can you see that there's an increase in size? When it swells up and becomes bigger, it will mechanically stretch the cervical canal as it becomes bigger. And after 12 to 24 hours, you can remove this and the cervix will be slightly dilated. Even Foley's can be removed after 12 to 24 hours. Okay, so these are mechanical methods. So how do we know that if you induce a patient, she will go into labor? Because after all, we are doing it artificially. There is no guarantee that her cervix will start changing or she might start getting uterine contractions. The best way to predict is what we called as a modified Bishop score. And this is again one of the questions that was asked in the recent INICET. Okay, so I thought we'll look into the score more in detail because the question list was on calculating the Bishop score. There are 5 components in the modified Bishop score. First is the dilatation of cervix. Second is the length of the cervix, otherwise the effacement of the cervix. Third is the fetal station. Fourth is the consistency of the cervix. And fifth is the position of the cervix. And based on how the different components of each of these components, you give it a score of either 0, 1, 2, and 3. And you calculate, add up all of the 5 components and you'll get a score at the end. And depending on the score, you can say if the patient will have a favorable or an unfavorable outcome. Okay, so let's look at it one by one. Dilatation of the cervix. If the dilatation of the cervix is 0, that is no dilatation, you give a score of 0. If it is 1 to 2 centimeter dilated, you give a score of 1. If it is 2 to 4 centimeter, 3 to 4 centimeter, you give it a score of 2, and 5 to 6 centimeter, that is anything more than 4, you give it a score of 3. Okay, so the highest dilatation gets the highest score. What about length of the cervix? If the length of the cervix is more than 4 centimeter, which means that the cervix has not started effacing or not started going into labor. In other words, if the effacement is 0 to 30%. Okay, that is thinning of the cervix is only up to 30%, you give it a score of 0. If the effacement is 2 to 4, or if the length is 2 to 4 centimeter, that is, it is starting to become shorter, or the effacement is 40 to 50%, you give it a score of 1. If the length becomes 1 to 2 centimeter, it is starting to become even more shorter, or effacement is around 60 to 70%, the score is 2. And if the length is less than 1 centimeter, it is almost becoming papery thin, or the effacement is more than 80%, you give it the highest score of 3. Next is the fetal presenting station. This is the only component that is involving the baby's characteristics, or the baby's component. Everything else is that of the cervix. If the fetal head is at -3 station, the highest station, you give it score of 0. -2, a score of 1. -1 or 0, you give a score of 2. Anything more than +1, that is +1 to +3, it is 3. Okay. Consistency of the cervix. If it is nicely firm or hard, usually firm consistency, it is 0. Medium consistency, it is 1. If it starts becoming soft, then it is 2. There is no score of 3 for consistency. If the position of the cervix is more towards the posterior side, or if it is pointing towards the posterior fornix of the vagina, you give a score of 0. If it starts coming to the mid position, it is 1. If it starts going towards the anterior fornix, it is 2. There is no score of 3 for position again. So please note these two, okay? For consistency and position, it stops with this highest score of 2. There is no score of 3. So the score can range anywhere from the lowest of 0, if all of these 5 is 0, or if all of it is at highest. The highest of dilatation is 3, highest for length is 3, highest for station is 3. So that is 3 plus 3 plus 3, that will be 9. Highest for consistency will be 2, so that will be 11. And highest for position is 2, 11 plus 2 will be 13. So please note that the highest score is not 15, but it is actually 13. So it will range from 0 to 13. And Williams says that if the score is less than 4, it is unfavorable cervix. And whereas if the score is more than 9, we call it as favorable cervix, and there is very high chance that she will go into labor and she will have a normal vaginal delivery. Okay, so this is what we call as the modified Bishop score. Since a question was asked on it, it might be better to memorize this. All right. Let's look at a question from Bishop score. Which of the following is not a component of simplified Bishop score? This is another score called a simplified Bishop score. Your options are effacement of cervix, station, dilatation, and consistency. Here, simplified Bishop score contains only 3 components in comparison to the traditional 5 components of modified Bishop score, and it involves effacement, station of the fetal head, and the dilatation. Consistency is not a part of the simplified Bishop score, and hence the answer would be this. Okay. The advantage with this is that it is simpler to calculate because there's only 3 components, and the prediction rate of whether the patient will go into labor or not is similar to that of the modified Bishop score. All right. Let's look at another MCQ. Which of the following is not true regarding misoprostol? Options are: can cause tachysystole, can cause meconium staining, can cause fetal heart rate abnormalities, and less effective than PGE2. Now, all these pharmacological methods, or you are using a type of prostaglandins, isn't it? And because we are giving it in an artificial method, the benefit that you want is cervical dilatation and uterine contractions. But sometimes it can cause exaggerated response and cause some complications or side effects that we do not want. If there is exaggerated uterine contractions, it can cause something called as tachysystole. Tachysystole means having more than 5 contractions in 10 minutes. What you're aiming in labor is 3 to 4 contractions in every 10 minutes. If there is frequent contractions, we call it as tachysystole. Okay, so this is one of the known complications of pharmacological methods, both misoprostol and dinoprostol. Something that is very unique to misoprostol is because of this tachysystole, every contraction of the uterus is like squeezing the baby. So it's a stressful event to the baby. And when the baby becomes very much stressed, it passes meconium into the amniotic fluid around. So it can cause meconium staining of the amniotic fluid. This is something that is seen more commonly in misoprostol and less commonly in dinoprostol. And because with the same explanation, with if there is frequent contractions or very strong contractions, this can suffocate the baby or cause stress to the baby and cause fetal distress, which can be seen in the form of heart rate changes in the CTG. Okay. So these are some of the complications that is seen with the pharmacological method. If the patient has had previous LSCS or any other scars on the uterus, because of these strong and frequent contraction, it can cause rupture of the scar. This is a very, very serious complications, and this is why prostaglandin or pharmacological method is a strong contraindication in previous LSCS or any scarred uterus. Okay, please remember this. So the option here you can rule out, misoprostol can cause tachysystole. From what we have seen now, it can cause meconium staining, can cause fetal heart rate abnormalities. It is more effective than dinoprostol. So your option is D. Okay, this is the not true option. Okay, of all the inducing agent, misoprostol is the strongest of all. It is very, very effective, but it has to be used in caution because it is, as much as it is beneficial and as much as it is very efficient, it has the same amount of very strong side effects as well. That is the downside. It is like a double-edged sword. All right. So what about mechanical induction of inducing agents such as Foley's and laminaria? This causes cervical dilatation only by the stretching mechanism. So is there any complications? Sometimes if you do it very forcefully, it can cause rupture of membranes. It can push the fetal head high up. If you leave it for too long, or if you do it under aseptic precautions, it can cause infections. And one of the complications with laminaria tent is that it can get lost inside the uterus. You leave it inside the cervix, but it can migrate into the uterus and you might not feel the thread. The thread along with the laminaria might get lost into the uterus, and in which case it might be very difficult to retrieve it out. So these are some of the complications with mechanical, but it can avoid exaggerated uterine contractions. So for the same reason, all these complications like tachysystole, meconium, fetal distress, these are complications that are not seen with the mechanical method. That is why in previous LSCS, this is the inducing agent of choice, or in scarred uterus. Okay. So this was a brief discussion on inducing agents. I hope that was useful. I'll see you tomorrow again with another important topic.
Good evening, friends. So today, actually, I wanted to discuss about mucopolysaccharidosis, but then when I went through the question papers and all, I thought that it is equally important to discuss a little bit about the chemistry of mucopolysaccharides and to know about the important facts regarding mucopolysaccharides. So today we will be discussing more about the chemistry and the facts, and on Monday we will be discussing about the Sorry for the interruption. So we were talking about the mucopolysaccharides, that is glycosaminoglycans. They are otherwise called as glycosaminoglycans, right? And these glycosaminoglycans are basically unbranched heteropolysaccharides composed of disaccharide repeat units. And each of this disaccharide repeat unit is composed of amino sugar and uronic acid. And it was first isolated from mucin. Hence, it is given the name mucopolysaccharide. Mucopolysaccharide, right? Now, to understand more about this disaccharide units, they can be either amino sugar or they can be acidic sugars, right? if they are amino sugars, they can be either glucosamine or they can be galactosamine. And if they're acidic sugars, they can be either glucuronic acid, or they can be irudonic acid. Irudonic acid. Now, what is irudonic acid? It is of glucuronic acid. It's an epimer of glucuronic acid. So, having understood this, let's look at the properties of glycosaminoglycans. Now, these glycosaminoglycans have a large number of negative charges, and these negative charges are contributed by the CO minus acetyl and sulfate groups, right? And because of this negative charges, they are like charges, they repel each other. They repel each other, which gives them the slippery consistency, the mucus-like consistency. Like now, the important thing is they attract a lot of water, and they are attract water. And they can actually be squeezed into small areas. But after they are squeezed into the small areas, and once they are released from that, once the compression is released, they get back their original shape and they get filled in with the them because of the repulsion back to come back. Now, this can be typically seen in two situations. Number one, the synovial fluids and the vitreous humor. The vitreous humor. And this ability to bind with water, the ability to bind with water makes glycosaminoglycans an important constituent of the extracellular matrix. Now let us look at some of the biologically important glycosaminoglycans. Now, hyaluronic acid. It is basically the disaccharide repeat unit that comes here is N-acetylglucosamine with glucuronic acid. And this is seen in skin, synovial fluid, right? Umbilical cord. Okay, remember this umbilical cord and a lot of other places, cartilage and all. Then you have your chondroitin sulfate. It is made up of N-acetyl galactosamine plus glucuronic acid, and it is seen in cartilage. It is seen in cartilage, bones, right? Cartilage and bones. Then we have the keratin sulfate 1 and 2. Okay, they have the disaccharide repeat unit here is N-acetylglucosamine and galactose. N-acetylglucosamine and galactose, and it is an important part of cornea. Along with, there are other places where it is found, like cartilage and large bones. Then we have heparin. Now, heparin is it is present in mast cells. It is present in mast cells. It is present in mast cells, and liver are present extracellularly, but heparin is a glycosaminoglycan which is present intracellularly in the mast cells along with liver and lungs. Then we have our heparin sulfate, that is glucosamine with glucuronic acid, and these are found in skin, kidney and all. And then we have the dermatin sulfate, the N-acetylglucosamine with hydronic acid or glucuronic acid, and this is extensively found in skin and has a wide distribution. It has a wide distribution. right? Then coming to the key points about some of the biologically important glucosaminoglycans. Now, hyaluronic acid, it is the one which is found in bacteria. It is found in the bacteria and in the extracellular matrix of most animals. The important role this plays is in the cell migration and morphogenesis, along with wound repair. These are the important places where hyaluronic acid comes into play. Then we have chondroitin sulfate. Now, the important thing here about chondroitin sulfate is it is important for calcification. It is important for calcification and is usually found in the places where bone calcification takes place, in the endochondral bones, right? Then keratin sulfate 1 and 2, these are usually found in the cornea and helps to give the transparency of cornea. Transparency of cornea. Then coming to heparin. Now, like I told, most of the glycosaminoglycans are extracellular, but heparin is intracellular, and it is found in mast cells. Then, along with glucosamine, it can have either of the 2-uronic acid. That is, it can have glucuronic acid or iridonic acid. The majority of it is iridonic acid. It acts as an anticoagulant. And is important for the functioning of lipoprotein lipase. Okay, this lipoprotein lipase is present in the endothelial walls, and to bring them into the circulation, heparin plays an important role. Okay, now coming to heparin sulfate. In heparin sulfate, the important thing here is the uronic acid here is glucuronic acid. Glucuronic helps in cell growth and cell communication. 2 places, right? And it is the glycosaminoglycan or mucopolysaccharide that is present in the kidney basement membrane and helps to give the charge to the basement membrane. We know a lot of pathologies are associated with the charge of the basement membrane, and it is this heparin sulfate which helps to give the charge to the kidney's basement membrane. Okay, and dermatin sulfate is present in skin, and it is very wide distribution. Right? Now, coming back to our question, which of the glycosaminoglycan present in cornea? Yes, you are correct. The one is not chondroitin sulfate, it is keratin sulfate. It is keratin sulfate. I'm sorry for the wrong marking. The correct answer here is keratin sulfate. Okay. Since this question has been asked recently, it is very important that we answer few of the questions with such facts. Okay, such as which of the glycosaminoglycan with no uronic acid? Glycosaminoglycan with no uronic acid. The answer is keratin sulfate. There is no uronic acid. Which of the glycosaminoglycan with no sulfate group? The answer is hyaluronic acid. Hyaluronic acid. Which is the glycosaminoglycan found in bacteria? Again, it is hyaluronic acid. Which glycosaminoglycan acts as an anticoagulant? It is heparin. It is heparin. Okay. Then, which is the most abundant glycosaminoglycan? The answer is chondroitin sulfate. Chondroitin sulfate. Okay. Which is the site of synthesis of glycosaminoglycan? Glycosaminoglycans are synthesized in endoplasmic reticulum and Golgi bodies. And Golgi bodies. What is the shape of the proteoglycan monomer? They are bottle brush shape. Okay, that is something like this. The brush that you use to clean bottles, the bottle brush shape. It is the shape of the proteoglycan monomers. Glycosaminoglycan that helps in cell migration. Correct, it is hyaluronic acid. Hyaluronic acid. Okay, and again, glycosaminoglycan that plays a role in corneal transparency. It is keratin sulfate 1. Keratin sulfate 1. Okay, now which is the glycosaminoglycan which is not attached to the core protein? It is hyaluronic acid, not attached to the core protein. It is hyaluronic acid. Okay. Now, as seen in the recent INISET, we have pictorial questions. So this is the question on mucin clot test, or otherwise called as rope test. Okay. What is this used for? Rope test is basically used to identify hyaluronic acid, to identify hyaluronic acid. Okay. Now, in a normal situation, if you add acetic acid to synovial fluid, you will get a ropey clot, and that is a positive mucin clot test, otherwise called as a rope test. So that's my time for today. We will have a discussion on mucopolysaccharidosis on the next day. Thank you.